So we showed them microbiologically what was on their necks and what was on their hats and just laid them out on it, no names. This is why we're concerned. And you're doing orthopedics drilling and reaming, and you're shaking like a salt and pepper shaker over a patient's incisional site. I mean, you have to get graphic like that sometimes to really put it in their face. Like, I have better things to look out for than not covering your hair or washing your hands or talking during surgery. So,
Infection stops where information starts. Welcome to the Transmission Control Podcast, where knowledge is your strongest defense. Broadcasting from the front lines of healthcare, we dive into the strategies, science, and stories shaping infection prevention today. Each episode, we connect you with experts on real-world insights to help you stop the spread of healthcare-associated infections, protect patients, and strengthen your practices as an infection prevention and public health expert. When the right information reaches the right people, lives are saved.
Hello and welcome to Transmission Control. Today we're talking with Maureen Spencer and Peter Graves about rethinking the perfect survey in the operating room. We'll talk about how IPs can feel more comfortable in the OR, build relationships that are necessary for compliance, and hardwire some of the practices that are common citations when the surveyor comes around. We'll be back after a brief word from our sponsors.
Brought to you from the studios of Healthcare HQ, let's get into it. This is Transmission Control.
Hello and welcome to the Transmission Control Podcast. My name is Garrett Hollembeak, Editor-in-Chief of Transmission Control, and I'm joined today by my co-host, Jill Holdsworth. Jill, how are you?
Hey, Garrett. I'm doing great.
Good. And are you enjoying a little bit cooler temperatures after we were in Phoenix, let's say last week?
Well, in Atlanta, the temperatures are always kind of hot, but I did enjoy the lack of humidity in Phoenix. I don't know about you guys.
Yeah, that's when people say it's a dry heat, it's like, yeah, but at what temperature? I mean, even then, we were talking with our guest before the show started, hitting 121 degree temperatures, working in the field as a firefighter. So thankfully it wasn't that hot in Phoenix, but we are excited about the show today. And we're going to invite Maureen Spencer and Peter Graves on to talk about rethinking a perfect survey in the operating room. And we know from our conversation with Melanie last season that the OR can be kind of an intimidating place for infection prevention. If you're newer, you may not know where to stand, who to talk to, or you're going to be in the surgeon's way. And I think that can impact our preparedness for survey to some degree. So without any further ado, I want to introduce Maureen Spencer and Peter Graves. How are you guys?
We're doing great. Thank you.
Yeah. And Maureen, let's start with you. Tell us a little bit about yourself, your current role, and your experience in the OR.
So my career in infection prevention started actually back when I was 15, when I got a job in a microbiology lab up at Boston City Hospital. And when I was 20, graduating from nursing school, the administrator called me up and said, you're a nurse and a micro background. Would you like to set up our infection control program? So that was at a 300-bed hospital up in Boston. And from there, I went to a VA medical center where they had the spinal cord injured and open heart surgeries from the patients from the Vietnam War. And then we get into the 80s, and I was the director at Mass General Hospital for 11 years. And then I became a corporate director at Universal Health Services, overseeing 28 hospitals in 7 states and traveling every week, doing surveys. So I became really an expert at surveys with a collaborative team of 7 of us. We have medication safety, food and nutrition, quality nursing, infection prevention, life safety. It just was fantastic because I got to learn really the whole picture of what we need to do for surveys. So that's been my background since I was 20 years old. I've been doing this job.
Well, that's pretty incredible. I feel like you're the best friend to have in your back pocket to be able to pick their brain and ask all the questions, because you don't normally have somebody that has that kind of experience for that long in survey readiness.
Let's just say that. And then Peter and I set up, we met about 5 or 6 years ago, and we just really clicked. He did a study with me at UHS in our operating room with colorectal surgeons and surgical irrigant. And we set up this company called Surgical Infection Consultants. And that's what we've been hired to do, to come into hospitals with unannounced, with our 2 lenses of eyes, not the typical survey team. And boy, we devour the place. We just go into every closet, every cart. We review everything. We have a whole list of things that we look at. So we've been doing that maybe now for about 4 or 5 years. Just before COVID, we started.
Wow. That's incredible.
It's fun.
Yeah. Peter, the audience who may not know you or be familiar with your great work out there, tell us a little bit about yourself and how you got to the show today.
So my name is Peter Graves, and I'm a unrepentant OR director leader. So a lot of people, particularly in the infection control space, are very uncomfortable working with the OR staff. And I really want to kind of demystify that piece, because we really are a partner. But I started in healthcare back in the late 1800s, but it was actually the 1980s. I started off in the ER, ICU area, went over and opened a brand new hospital in the operating room, moved up through the leadership roles as a clinical educator, OR director, got hired into medical device, focused on infection control, really worked hard with trying to change behaviors, things like double gloving, antimicrobial irrigations, and so on and so forth. And this is where Maureen and I work together so closely. On top of that, I used to sit on the National Board of Directors for AORN. I wrote the original transmissible infections guidelines for AORN. So I've been kind of the OR infection prevention geek guy, for a better term. And partnering with Maureen made total sense, because I like to think of us, I kind of nicknamed us the unicorns, because there's nobody else doing exactly what we're doing in the United States, in fact, globally. And we're getting a lot of traction with hospitals asking us to come in and take a look, because we look at things from 2 different lenses. We look at it from the lens of a seasoned infection preventionist, and then also we look at it from the lens of a OR director, educator, and somebody who's written guidelines. And so I think that really comes into play for really helping some of these people that are having issues with infections or challenges for whatever reason, really helping them kind of get grounded, for a better term.
Yeah. I think that arm-in-arm approach has to be some of what makes it unique, that you have both somebody with OR experience, somebody with infection prevention experience, and that you are able to see things with that joint perspective. Sometimes accreditation goes one way, life safety goes another way, and IP is just kind of floating out there. It sounds like bringing those lenses together gives a better perspective for everybody.
I like to think of it as more like a common sense approach, because when we meet in the middle, we really do solve a lot of problems. And I think that's where one of the big challenges, particularly today, because we have a number of different infection preventionists that are not clinical in nature. And so I think this is the part that I really want to kind of invite them into the operating room, for those MPHs and those that are not clinical in background historically, that you really do need to partner with your colleagues in the operating room to learn how and learn what to look at.
Now, when we look at some of our more common elements of a Joint Commission survey where we see citations, what are some things that surprise you that sites get surveyed for? And what are some of the more common things in the OR space that facilities are getting cited on?
Yeah, I can address that. From the infection prevention point of view, I think surgical attire is still an issue. And I always say, when I'm surveying, like if we go into a pharmaceutical firm or go into a medical device company, they take painstaking measures to not have any of that equipment contaminated. So you get a sterile product for the sterile field. And yet you have people with their hair hanging out, people are talking on their phones, their masks are under their nose. The things that we see are there, the instrument reps are right up into the field, breaking technique. And I think a lot of it's just lack of education. A lot of them are just not, or enforcement. The other one is disinfection and sterilization. That's still a big issue. I think more and more now that we have such problems with staffing levels in, say, a SPD department of central processing. And they just work so hard to try to get this equipment, especially with orthopedics, which is where I really got a lot of my experience in this whole concept of the OR. And I developed a 7S bundle approach to pre-op, intra-op, and post-op. And seeing it from that lens, that kind of equipment, those tables that they have to prepare and clean all that equipment. The other one is hand hygiene still. I mean, all these years I've been doing infection control, I feel like a mother running around telling them, wash your hands, clean the equipment, clean up after yourself, clean the environment. It just really bothers me that at the professional level we're trained, and studies will show that surgeons will often have less hand hygiene compliance than a CNA. It's like the arrogance. And that's what we chase around for careers, arrogance and anger. They just won't do it.
The motto of IT.
Anyways, those are some of them. Lack of medication safety is a big one under the medication management, and also lack of leadership. They're being cited on if they see that the IP program is not having the support that they need for implementation, clinical implementation. Yeah.
So, Maureen, I want to go back to the very first thing that you said, the surgical attire, hair hanging out, and for IPs, a lot of us have ran into pushback, the arguing, the anger that you mentioned. And some IPs that will be listening to this will be brand new IPs, some will be seasoned, but we all get the same pushback and we all have to deal with this. Some people would rather avoid it, like the plague. And I guess what I want to know from you is, what would you suggest as the best way to approach this? Because some people, you'll walk up and say, hey, is that hat freshly laundered? And they're like, oh yeah, I laundered it. And you've literally seen them wear it for 5 days. Or you'll ask them, are those fake nails? And there obviously are. And they're like, no, these are my real nails, but they're perfectly manicured, the same length. People will lie and push back till they're blue in the face. So what do we do? If they don't care enough about their patients, what else can we do if it's not for the patients? That's not motivation enough.
All right. So that particular topic I have dealt with at the corporate level. When we were implementing the surgical attire policy, I had to write one just to write a template for them. But what we did was we had the IPs work with the OR directors and HR, and we made it a dress policy. I mean, this isn't an IP issue to chase around people to like what you said, is your hat washed or this and that. This is something that should come from the top down. Is a compliant. This is the standard. This is our dress policy. You adhere to it. And then it goes up the chain that way, rather than IPs think that they have to take that on. So that's real. And the other is data drives your program. I can't say that enough about everything. Observational studies. Get up in the OR, collect some data. You know what I did? I did cultures. I cultured the back of the surgeon and anesthesia's necks, where all their hair was hanging out, and all the there, all the pimples were there. They let me do their lab coats. They let me do the top of their hats. They're telling you that they wash them. They don't. So we showed them microbiologically what was on their necks and what was on their hats, and just laid them out on it, no names. This is why we're concerned. And you're doing orthopedics drilling and reaming, and you're shaking like a salt and pepper shaker over a patient's incisional site. I mean, you have to get graphic like that sometimes to really put it in their face. Like, I have better things to look out for than not covering your hair or washing your hands or talking during surgery. So
you're right. That stuff should be the basics. We shouldn't have to spend our time on that stuff. We need to spend our time on the more complicated things.
Yeah. But it has to go up through the channels. And maybe, Peter, from being an OR director at Baylor, a big place, and what you were challenged with this.
One of the things I try to do is I try to proactively address some of these issues that you brought up, Maureen. And Jill, I think you've seen the same thing in the Atlanta area. It doesn't really matter where you are. We're seeing the same problems everywhere. So it's not a me problem, it's an us problem. first of all. The second thing is proactively work with your OR leaderships, your educators, your staff nurse, develop some champions. And really, I mean, it's no different than any other initiative that you're trying to overcome. The thing is that I live in the OR 24/7. You guys are oftentimes simply visitors once every couple of days or once a week or whatever your routine might be. And I think that the thing is that you're going to need to develop leadership champions for some of these initiatives that you're trying to develop. And if you're not doing that, then you're really going to be spinning your wheels and just getting more frustrated and start using 4-letter words to describe things. And it's really not going to solve the problem. The problem is that bugs are multifactorial, and these surgeons, you know, they're so busy looking at running their business and they're doing their other things that they're not always thinking about, to Maureen's point, the salt and shaker kind of routine that they're constantly over the. By the way, I love that analogy, by the way. They're not thinking about some of the implications that their behaviors have. I think all of us have heard the term, we've always done it this way. I think that's probably one of the most dangerous terms that we can ever use in an operating room or in a healthcare facility. Because if we do it the same way we did it back when Lister was around, really we haven't done anything different. And we have a lot of data and a lot of evidence and a lot of great products that are out there that can help us solve some of these problems. You know, one of the things I used to be challenged with, and having written guidelines, I developed pretty thick skin around like surgical attire. And, you know, I wrote one of those guidelines that everybody hated, you know, and so it's like, okay, I get it. I hear you, but I'm not changing it just because you don't like it. Because sometimes it's going to be the best practice. So no different than like Jill, when you were at your facility in Atlanta, it's no different than you having to kind of dig your heels and say, look, we have to do it this way. Sometimes it's those hills that we don't want to die on, we have to die on.
Peter, I totally agree with you. And I want to back up a few steps to something that you said in the very beginning, because not every new IP or even seasoned IP is going to feel completely comfortable going up to a surgeon and talking about their salt and pepper shaker and all of the risks. And like you said, a lot of people just aren't comfortable in the OR. They aren't comfortable around the circulators and the OR nurses. They're very intimidated. So I wanted to get your perspective on how to get the people that are listening here, give them some tips on how to get started, how to feel a little more comfortable doing those first observations or the first rounds in the OR so that they can start getting that data that Maureen talked about to drive the actions and the program that they need to do to start talking to the surgeons.
So that's a great question, Jill. So I think one of the things I always used to say is come in hungry, come in humble. Recognize the fact that you don't know it all. If you don't have clinical experience, if you came from a different role, like in a lab position or whatever it might be, come in humble, be hungry for the information, put on a pair of scrubs and mirror or partner with a circulator for a day. Kind of walk through a number of different procedures so you can kind of start feeling kind of the flow of how things go. You know, if I'm doing like eye cases, for example, that's a very fast, repetitive procedure. If I'm doing heart cases, those are sort of like an Army campaign case. They can last for quite a while. Or I'm doing transplants. You know, if I'm doing total joints, you want to try to limit the number of people you have in the room. You want to limit those door openings. So you're going to start wanting to make some observations and learning from what you're seeing. If they're not using things like smoke evacuators, if they're opening and closing the door oftentimes during the procedure, you're changing the air pressure in the room. So you can kind of take the AORN guidelines and some of the APIC guidelines and marry them together and start kind of integrating them into what you're seeing and what you know. And then you have the relationships already with the staff. Go have lunch with them, bring coffee, make the effort to build a relationship with the people behind the red line. And I think that's a really important thing to start with.
Yeah, the other one that I always recommend is to reach out to the OR director or manager and ask if you can get part of their new employee orientation to the OR, so that you're there seeing how an OR nurse or a scrub tech would be oriented to the OR. That's one. The other one is when you don't know the kind of surgery, you're having a cluster of cases and say a total knee, get on YouTube at night and start watching total knees. I had surgery last year and I can't tell you how many of cases I watched, so I know exactly what they're going to do in this particular surgery that I had in my hip. So at least you're going in saying, okay, I get the gist of what they're doing down there in the field. But then you're going to observe what's happening in the dirty zone, as we call it. Like Peter said, the doors opening and closing, the surgical attire, if they're on precautions, are they really following the precautions, and so on and so forth. We have like a list of things that we look at in the OR. That's kind of our checklist. I recently got asked by a MPH IP, Maureen, what would you do? They're asking me if we don't no longer have to wear masks in the OR because they don't do that in England.
I hear that all the time.
Oh, yeah. So your answer could be, well, here are the ARN guidelines, which most of them are not members of ARN. I recommend they get to be members of ARN. You can, even if you're not a nurse. And you can get a copy of the guidelines through the hospital. At least the OR director should have them and read them, the ones that are specific to our field. There's a whole bunch of them. And then the other thing is, for something like that, I said, let's do a little study. I go to the micro lab to get me some blood agar plates. We're going to go up, and I'm going to have them talk over the blood agar plates. Come on, just talk. And then incubate them, bring them back the next day. I've done this. So they can see what's all over the plates from them talking. So this is why we want to confine and contain, like we do with isolation, your oral secretions so they don't get into the patient. I had an outbreak once, alpha strep and co-ed negative staph in total knees. And it was my unit-based champions up in the OR. Like Peter said, I had two of them. And one of them came to me and said, I think I figured it out. They're using this new pain cocktail called, Dermorph, Toradol, and Marcaine, and they were drawing up each vial with the same needle and squirting it into a sterile specimen container, twirling it up in the dirty zone and passing it to the field. Now, I would never have been able to figure that out if it wasn't for her observing that practice for me. Because I kept saying, we try to figure this out. These are bugs from the mouth, alpha streps, and from the environment, co-ed negative staph. So you've got to have this really close relationship with them and be more innovative and trying to show them the bugs, like I said, culturing the back of their necks or their lab coats or their hats. And my lab was wonderful. They just backed me up, 100%. I had even a little budget in the micro lab for all these little studies I used to do.
That show and tell process is really unique, and I don't know how often IPs get maybe empowered to do stuff like that. Because one of the things we do here is, you're only asking us to do this because it's an AORN standard or it's a joint commission. And speaking about survey readiness, there is a sentiment that we hear sometimes that it's not really making an impact. We're only doing it because it's a standard and we don't want to get cited. So how should IPs speak to that mentality when we only do it because that's what joint commission or DNV or, IP is asking us to do?
Yeah, I used to get my support through the orthopedic staff meeting and the surgical staff meeting. I would go to those meetings and present, the SSI data every single month. And I would be assigned to do a grand rounds every year as part of their patient care quality team, having to have like one of these lectures every year. And so that was where I was able to really get the support from the orthopedic surgeons. And I took pictures, get patients, permission to take their incisions out, do all kinds of fancy studies and show them, at these meetings so that they could actually see what I was talking about. And when Peter and I do our surveys, that's how we do our survey report. We take pictures, put them in a PowerPoint presentation, and we put the citations with live links on who says this is the problem. And also get the evidence tables from the ARN guidelines. They have them on their website, a whole list of where did they get the references to make those evidence-based guidelines. And so, some surgeons will listen to the science and the data, and you have to convince them. And others will be more influenced by those other kinds of things I did, show me the bugs, and put them live on some plates. So you've got to be really creative. That's what I've always been throughout my and get a good relationship with the chiefs of the services. And with your hospital epidemiologist, the chairman of the infection control committee, through them, and get that good collaboration going.
And you're absolutely right. Every surgeon interprets things a little bit differently. I can remember telling people things during COVID and they would just say, tell me what that means. I don't know what you just said. And then other people want to know way more in depth the scientific details of things. And you almost have to learn every single surgeon's learning style because they're all very different. And as an IP, that's very tough if you have a lot of surgeons in your facility.
It's interesting you bring that up because it's very much an academic speak and then a very novice speak at the same time. And it's kind of hard to master that piece. And so, it's a little bit of art and science at the same time, being able to kind of walk that chasm between the academic, show up and throw up kind of just tons of data. And then also just making it so elementary simple for individuals that may not be licensed, that may be like your housekeeper that is new to healthcare. Because all of these people are incredibly important to the entire picture around prevention of infection. And so I think this is where, you're a little bit like an artist, being in infection control, being able to paint the picture for everybody to interpret. And that becomes very challenging sometimes for us.
It made me think of being an IP is sometimes like teaching a class full of elementary students. And you do have to learn each student's learning style. You talk to each of them differently. You can teach the whole class the same topic, but each one has to learn it differently. And that's kind of what we do every single day. And that's probably why it's so exhausting.
And it relies on those relationships too. Because if you don't know the student, if they don't know you, and you just show up to say, hey, these are the 9 things you're doing wrong, it can fall flat really quickly.
And they'll cry and throw a tantrum.
I like to call those behavioral challenges.
Okay.
Behavioral challenge. That's a very nice way to say it. And one of, at least in my experience, talking about pictures, talking about things that make an impact. One citation that we're hearing a lot about right now is point of use treatment in the OR and the impact that has not just on the instruments, but on the next patient that comes into the room. And if I could tell you how often this fight occurs with, we see it in SPD, how, gross soil is not removed, point of use treatment doesn't take place. And then you go back up to the OR and it's, I don't have time. It's not a real requirement, or it doesn't really matter because they're going to clean things anyway. So how do we speak to the importance of point of use treatment, especially knowing that that's, I think, something on surveyors' radar right now?
I think one of the challenges that a lot of people, and COVID, you guys have mentioned COVID a couple of times during here, but we've had a large talent drain after COVID, particularly in the OR, because the OR became kind of the polling point for people going to different units, shutting down non-essential surgery. And so we lost a lot of talent and experience in the operating rooms. So we have a lot of inexperienced people now, and that creates problems by itself. So I think one of the challenges are really starting with a fundamental or elemental educational program from a standpoint of, I like to think of it as, and Maureen, you mentioned this earlier about watching people with, and we've seen this in a couple of our last surveys, of walking around the hospital with masks hanging around the back of their necks. I don't remember the nose being on the back of the head. But they've created kind of a muscle memory, for a better term. So we really need to kind of create what's called muscle memory for individuals to perform these tasks, because that's really what you're talking about. This is a task. To do this correctly in the right order so that you don't have soiling, so that you start having this point of treatment, where you start defatting and you don't have blood drying on instruments. It's faster. You have better quality outcomes. You can marry that up with things like AI automation that's in SPD to help with tray assemblies. You have a lot of different tools that you can do to try to remedy this problem so that you don't have incomplete trays. You don't have poor quality coming in and out of the operating room. and out of SPD. I think that's one of the challenges that I see. The other thing that I would say that we've seen loud and clear is the difference between low-level and high-level disinfection, particularly around ultrasound probes. That's another thing that kind of keeps both of us up at night when I'm trying to be polite, Maureen, but it's sometimes what we found is gross, where we're not sure if it's sterile gel or unsterile gel. There's a lack of Sanitwipes to clean the probe heads. We're not sure if they're even being high-level disinfected. They're using them for patient after patient after patient, for epidurals, for nerve blocks, and so on. And then you add to that is, are we actually tracking these patients afterwards to see if there's any nosocomial or hospital-acquired conditions that occur post treatment? So, I mean, this for me as an OR person leaves me a little speechless sometimes when I go in and see some of these things.
Yeah, I did a study once of the Dynamaps. So there's, the equipment that goes from room to room to room to do temperatures, and has a blood pressure cuff, and it has a, pulse oximeter. And, were they actually cleaning this between each patient? So we first start with the control, like we're going to sample them all, sample each one of the pieces of this equipment. Then we're going to implement this process, because it's mostly CNAs that do it on the nursing units, that when you're coming into the room, you get your gel and you make a big effort in front of the patient to sanitize your hands while you ask for their patient identifier, name and date of birth. And you're really making this whole effort, because they're going to write that on their survey that they saw somebody sanitize their hands. Then you have on every one of the Dynamaps, the basket has Sani cloths, and you start wiping all the equipment down in front of them so they can see that you've done that. So we then implemented that program. Boy, it was so successful because we implemented it into a procedure they were already going to do, coming in the room. Okay, now sanitize your hands and then clean the equipment while you're asking for patient identifier. And we repeated it. And we actually presented the study years ago at Shea, and we showed that not everything was clean. There were no organisms on it. So we didn't have to go to disposable blood pressure cuffs. This worked. That was the reason we did the study. But, I got my master's in education and health promotion for the very reason that after 20 years, I was doing infection control. Why get an MPH and go and just describe the problem in fancy, statistics and so forth? The issue is, how do you change the behavior of healthcare workers? And the model that I've always had in my program is called social learning theory. So you have Bandora's work from California, role modeling, and that's where the unit-based champion program comes in. Also self-efficacy. So increasing the self-esteem of IPs, quote, unit-based IPs, and it was all departments, not just nursing units. I had them in radiology and respiratory everywhere. And then the next one, which came from Harvard, from reinforcement theory, Skinnerian theory. We're going to reinforce it, and we're going to give feedback, consistent reinforcement. And my thesis for my master's was in that, seeing if I could change the behavior of orthopedic surgeons at Mass General to wear PPE, double gloves, impervious gowns, impervious boots, and masks and goggles. And I had observers. And one was the control. We told them nothing. One group just got education. The next group got education and feedback because they didn't know who was observing them. And we were able to show that had the most intervention and changed the most behavior. The other two are contracting. I will pledge that I'll do better hand hygiene by these big cafeteria displays we did almost every other month. So I have a website called creativehandhygiene.com that shows you what we did, and had a lot of fun doing it. And reciprocity is, I'll give you something in return if you'll do this for me. Stuffed animals, pens, whatever we could give out. And we became so well known, our department, as the fun department, but also we had huge compliance with hand hygiene as a result of it. So you've got to figure out, as I said earlier, creative ways to get people engaged. They're so busy and overwhelmed that, you're just this one department trying to grab their attention. So that's what I did, and it worked really well, both at New England Baptist Hospital and UHS. We rolled it out across the country to our hospitals. So that's the other thing to think about. What would be your theoretical foundation to your infection control department? Changing people's behavior with clinical implementation.
And when you think about that, Garrett and Jill, I think one of the things that we noticed in the last couple of surveys we've done is there's a big problem with anesthesia and drug security in their anesthesia cards. So if we take kind of what Maureen was talking about, and we have somebody that's new to the role in infection prevention, one of the things I would say is go in and round on your anesthesia providers. Start making relationships with these anesthesia providers, because this is going to be something, based on what we found, there's not a single facility that's not going to get cited for this. And since we're talking about CMS and Joint Commission and DMV and all these guys that are coming in, whether it's a surgery center or an acute care hospital, medication safety is a big issue. And we found that the syringes aren't labeled, they're sitting out, they're being drawn up, repetitively. There's several of, particularly on like, let's say we're going to be doing a GI room that day, they're drawing up for 6 or 8 patients before the first patient rolls in the door. None of them are labeled correctly. They don't have patient identifiers on them. And so how do you know who's who? And so I think this is one of the things that's like, working with your anesthesia providers, working with your quality group, working with your risk manager, working with your anesthesia leadership, working with your OR people, because this takes a team. It's not an individual problem. And if it is, then you can kind of carry the stick a little bit. But at that point, we really do need to work together to solve this together so that we have a longer term resolution.
And that kind of, in a lot of ways, answers the next question I was going to ask for you guys as we wrap up here is, what is one thing that IPs listening today can go out and do tomorrow to help get to a better outcome for patient safety, for reduction of risk for the patient? What's something they can go out and do tomorrow to help drive better outcomes in the OR?
I would suggest that they meet with the OR directors and managers, because sometimes they're managements of different services, and offer their services to present the SSI data and other HAI data, just to give at a staff meeting, which they have staff meetings every quarter. Come in and talk about MRSA, come in and talk about C. difficile, come in and talk about, the SSIs. That's how I started. And so they got to know me. I had 15 minutes at their 6 a.m. meeting, so you've got to get up early to do this. We then developed kind of that relationship, and I started to round every week with the Unibase champion. So they would see me in the OR. I started to be seen as I was part of that culture. And also, like I said, attending those meetings. I attended all the grand rounds also, just so I could be seen. Half of it went right over my head, but I was there. So those are, I think, just easy things that they can do to start with, is just to get that relationship going, and then from there they can build on it.
The other thing I would say is go in and just start making friends, because, and I'm not talking about, BFF kind of friends, but start making relationships with everybody, from the surgical tech to the circulating nurse, to the educator, to the unit manager, supervisors, to SPD, all the players that are involved in surgical services. Go in there and just take the time, and I know that time is a commodity, but take the time early on in your career to make the relationships. I've been into facilities where the infection preventionist had to ask me as a visitor, where's the OR?
Yeah. Yes, we had that happen to us. We're like, whoa.
And so, to me, it's an investment in time. Go in and just look for how clean are the bins. Because that bin, if it's full of dust, number one, that tells you a lot right up front. First of all, they're not cleaning. They don't have a cleaning schedule. Number two, all of that stuff in the bins need to be wiped down so that when I do bring it in the room, I'm not bringing in particulate matter into the operating room. Because from the very beginning of what Maureen talked about, our cell phones are produced in ISO clean rooms, and we're doing surgery with a door opening and closing multiple times during the procedure, and our particulate matter is through the roof. So one of the concerns I have is just look for simple things like that you can help them with, help coach them with. Because I think if you can start developing those early relationships and that trust amongst the teams, that'll do you great.
Yeah. I thought of one more thing. We implemented at UHS the Joint Commission Tracer methodology. It was part of quality, and they typically do that. And we had the traces for infection control. So I rewrote them, kind of personalized them to UHS, and even wrote additional ones. We had 13 of them. And, they were like the operating room and central processing, wound care, the ICUs, and so on and so forth. They were assigned to do 3 of them a week. And at first I got so much pushback. And I said, I'm sorry, you need to be in these departments, at least three departments a week. We're just going to do this. And it would take you only an hour. Well, after 6 months, and then the tracer methodology results came to me, and I could then collate all that together, and I could figure out from a corporate perspective, what are my challenges? What are my priorities? And guess what it was? Endoscopy. It was like, challenges with disinfection and sterilization. They got to be known. They knew they were coming every month. They were going to do this survey with themselves, and they had the list of what they were going to look at for continued readiness or any problems that would come up. So that can be a method, kind of a legal method, like, hey, this is a program we're going to implement, and we're going to do this every month, supported by administration, and those results are then going to be collated so we can kind of see overall throughout the year what our problems are for our infection control plan for the following year. What is it we need to focus on? Leave the things that are going well alone, but here are our challenges. So I can't say enough about that. I'm just really impressed with that Joint Commission methodology system.
And I think that to me, when we look at that, Garrett, I think one of the things that's kind of like, okay, that's the elephant, but we can't eat the elephant in one bite. So it's going to take, if we take small bites, we'll eventually eat the elephant, but we're going to solve the problem. So I think patience and consistency is really important here.
And you read my mind, because there's that adage of how do you eat an elephant? You do it one bite at a time. And as we close out, I think you guys have given us some really great kind of, I'll call them bite-sized insights that every IP can go out and say, this is, the big OR problem, but we can tackle it consistently, step by step, using good data, best practices, reliable guidelines. So I want to thank you both for sharing all of these insights and breaking it down to where it's actionable for the audience. We appreciate your guys' expertise and coming on the program to keep our patients safer. Thank you.
Enjoyed the time with you guys. Make sure if you have questions, reach out to our website. We're happy to help you.
Well, Garrett, that was a lot of fun, and a couple of things that I really liked that Maureen mentioned right in the beginning was let data drive your program. And I think that's super important, especially when you're dealing with surgeons and people in the OR. They don't want you just to come in and say, you need to do this different or that. They want to know the why. Show me the data that shows why I need to do this different. And I also love that she said, just be seen. We have had that as kind of a recurring theme in all of the episodes so far on transmission control, that you just need to be present. You need to be seen as a regular figure in all of these departments so that they see you as the IP, the partner, not the auditor.
Mm-hmm. And she touched on social learning theory. And I think it's one of those early chapters of the APIC text that kind of we read it, and then by the time we get to the end, we forget about it. But that really is a driver of hardwiring good practices, changing the culture, and making sure that the staff knows if it's important for the patient, it's going to be important to the IP. So wonderful episode from Maureen and Peter. And we got a lot of great new information, because infection stops where information starts. Thank you.
Thanks for tuning in to the Transmission Control Podcast, where infection stops because information starts. If you enjoyed this episode, let us know. Connect with us on LinkedIn, Facebook, or wherever you get your podcasts. Don't forget to leave a 5-star rating and share this episode with your team. Until next time, stay informed, stay vigilant, and keep transmission under control.